स्क्रीन विजिबल है?
विजिबल तो है लेकिन मूव नहीं कर रहा, एक आइकन पे आके अटक गया है। हाँ अभी विजिबल है।
अभी विजिबल है ना?
हाँ एक बार आप एक्सपैंड कीजिए। या
अभी ठीक है
वेल
ना?
लेट अस स्टार्ट।
Okay, so am I audible?
यस
Hello.
सर।
Okay, so now today's topic is approach to pancytopenia. Is it clearly audible and screen is sharing, right?
यस सर, ऑल इज गुड।
Okay, great. So this is very important topic regarding the not only the PG student, for a general pediatrician as well as for hematologist, pediatric hemato-oncologist. We get a lot of call for pancytopenia. That is fine. That is mainly a CBC finding most of the time. So we have a systemic approach to the pancytopenia. We have to see each and everything, because pancytopenia is only the your report is showing this thing. So you have to go to the cause of the pancytopenia, because most of the causes are treatable cause. Rarely we find any cause of pancytopenia which is not a treatable cause. Otherwise most of them are a treatable cause. So going to that, before that, how we define the pancytopenia. So as name suggests, pan means all, cytopenia means cell lines are deficient. So a disorder characterized by an abnormal reduction of all of the three cellular elements of the blood, including red cells, white cells, as well as the platelet, that result from a number of the disease process. So you can see here marrow, if there is a if from the marrow, red blood cells are produced, white blood cells are produced, platelets are produced. So if they go all the three lines suppressed, then it is called a pancytopenia. This is the most important slide of this presentation, and I will use this slide repeatedly to reach the diagnosis. So once we go in details of a pancytopenia, just have a look on this systemic approach to pancytopenia. When somebody says pancytopenia, it means they may come with some sign and symptom. For example, because neutrophils are low, so they may come with a sepsis or other thing. But pancytopenia must be confirmed on a CBC, confirmed on a complete blood count. And first and foremost reason may be the drug or toxins that we discuss in later. If some immediate history of some drug that cause a pancytopenia should be ruled out, and then your initial workup start. You see, the peripheral smear is the most important, along with the CBC, which tells you a lot of things. If, for example, in peripheral smear, you may find blast, you may find all the three cell lines are decreased. Definitely, you are dealing with the leukemia or sort of thing. So it will give you the urgent or immediate diagnosis. Or PS is the window to your bone marrow. Okay, now so three things. One thing is you have to remember. First is if peripheral blood is showing a macrocytosis, three differential diagnoses come in your mind. One is a megaloblastic anemia, very common in Indian setting, where folic acid, vitamin B12 deficiency can cause megaloblastic and raised MCV. It could be a myelodysplastic syndrome, and it could be aplastic anemia. And aplastic anemia can be because of the various reasons that we will discuss further. Okay, coming to the next workup, what you will do, you have seen the peripheral smear, you find the megaloblasts are there or whatever. So you will rule out what other deficiency can cause, or what other factor associated with your this blood picture. So you will do your B12. If it is autoimmune, you are suspecting Coombs test, or because of the deficiency of the copper, and so on, or autoimmune ANA you would like to do. Now, as for anything, if something is decreasing, either their consumption has increased or production has decreased. So where the consumption has increased in an autoimmune hemolytic or autoimmune diseases, like we have seen in a SLE mediated or something else, splenic sequestrations, that is maybe some autoimmune hemolytic anemias, and there may be a production disorder. So what are the production disorder? Can be nutritional, because your Raw material is not there. For example, somebody is having a deficiency of B12 because of there is no absorption because of some other reason or whatever, malabsorption is there or pediatric surgery is there, eating disorder, they are fuzzy about the food, strict vegetarians, alcoholic, then there is a higher chance of nutritional deficiency. You will replace vitamin and all, and you will find a normal CBC in due course of time. Non-nutrition can be there. So if you suspect non-nutrition, here is bone marrow is needed. Otherwise, in nutritional, most of the time, to diagnose nutritional pancytopenia, you need not to do the bone marrow, but to differentiate from other disorder, you need this bone marrow aspiration and biopsy. Biopsy is the most important part. Bone marrow may be hypoplastic, that is, so you have to go with the cytogenetic in fish. You want to know whether it's acquired aplastic anemia or it could be hypoplastic MDS, and or it could be a congenital bone marrow failure syndrome. We will discuss one by one. Okay, and other is a malignancy, where that is also non-nutritional cause of a production defect, maybe primary hematological malignancy like acute leukemias, or metastatic disease like neuroblastoma, where all these malignant cells goes to the bone marrow and production decreases. Coming to the peripheral destruction, so where both the causes are there, where peripheral destruction is increased and production is also low. For example, paroxysmal nocturnal hemoglobinuria or hematological malignancy. For example, acute leukemia, there are so many blasts are there that normal cells are not producing, and whatever the normal cells are there, they are breaking down on autoimmune condition, HLH syndrome, and few drugs. This is the crux of the whole presentation. With this, we will go to the causes of in detail. So pancytopenia, you have diagnosed on your CBC, you have seen your peripheral smear. It could be a central because of the bone marrow failure, as we have seen, as well as peripheral destruction. So you know central, now it's like a revision sort of thing. Central, aplastic anemia because of the drugs, because of the viral infection, because of the MDS, malignancy, or peripheral restriction because of the hypersplenism, autoimmune disorders, and severe sepsis. If you go with this chart or previous chart, you will reach to diagnosis most of the time. Now, what is the etiology of the pancytopenia? So it could be a malignant or non-malignant. So this is from one of the paper. And if you find that non-malignant causes are the most important cause, 80%, 79 to 80% are because of the non-malignant, and whatever the remaining 20% around because of the malignant region. Non-malignant aplastic is the most aplastic, and megaloblast, sorry, dietary is the megaloblastic is the more common cause of a non-malignant cause of a pancytopenia. As we have seen, where you find an empty marrow. So marrow is not producing. Why? Because of the aplastic anemia, because of the hypoplastic MDS, or a myelofibrosis, or infiltration by abnormal cell like leukemia, lymphoma, solid tumor, or miliary tuberculosis, for example. Deranged marrow, myelodysplastic syndrome. Starved marrow. Marrow is starved because it is not getting a raw material like B12 or folic acid. Drug-induced chemotherapy because of the direct effect on a bone marrow like chemotherapy, or antibiotic like sulfur drug or alcohol, or maybe immune mediated. Coming to the what are the causes of aplastic anemia, because aplastic anemia we find in our common practice. So you have to have a systemic approach. You have diagnosed this, it's okay, it's a aplastic anemia, whether it is acquired or it is the inherited one. Acquired is the most common, where you find some or other causes there. Inherited, you know this, there is some genetic cause, predisposing causes there for aplastic anemia. Coming to the acquired, most of the time you don't know what is the cause of this acquired aplastic anemia, and sometimes you know that secondary to viral, drug, etc., marrow is not able to form the progenitor cells or RBCs, WBCs, and platelet in a periphery. Inherited, Fanconi's is the most common, then Schumann diamond and others. We will discuss one by one in detail later on. So secondary can be a radiation. For example, some patients of a solid malignancy receive the radiation, they have higher chances of developing a marrow failure because of this secondary to radiation, because it also inhibits or it also wiped out your marrow. Drugs, chemical like anti-cancer drug, gamma benzene, chloramphenicol. Chloramphenicol has a reducing effect on a marrow function, and some anti-epileptic acids and colds. Few virus infection, you have to rule out some viral infection as a cause of acquired aplastic anemia like EBV, hepatitis, parvo B19, and HIV. and thymoma can also lead to the aplastic anemia. So hepatitis, prior episode 2 to 5% to 24%, aplastic current 0.07%, usually non-A, non-B, non-C, rare with hepatitis A and B, is when severe this aplastic anemia may respond to androgen, ATG or BMT. Parvovirus B19 that cause transient aplastic crisis in disorder with erythroid distress. So what are the causes of erythroid distress? You know that sickle cell or thalassemia or hereditary spherocytosis, head drops following in utero infections. So Parvo B19 is a very notorious. If we have seen in oncology practice, somebody is in a maintenance chemotherapy, they are receiving some immunosuppression and they come with the low count for a prolonged time period, and we found a few patients which are a Parvo B19 positive, that is causing a not only a pure cell aplasia, but it is causing a pancytopenia. So it is an important cause. What are the causes or a mechanism of a pancytopenia? It could be a direct toxicity. For example, parvovirus. It causes cell lysis. You will not get the, and there is a deficiency of the hematopoietic cells. Immune mediated, like hepatitis, there are shared epitope and shared epitopes that lead to your autoimmunity, and there is a decrease in the progenitor's cells. Now, genetic inherited aplastic, we know this in pediatric practice. We come across Fanconi anemia, Sherman-Diamond syndrome, familial aplastic anemia, amagokaryocytic thrombocytopenia, dyskeratosis congenita, reticular dysgenesis. They are the but rare cause. The acquired cause is the common cause. So this is the summary. We will also repeat it again because these are some interesting for us as well. For example, Fanconi anemia that predisposed to the other MDS like AML and squamous cell carcinoma or vectoral deformity. You know the clinical feature, they may have a Caffeine spot, microcephaly, or developmental delay. What gene affected is a several genes. So they have named from FANC-A to FANC-Q, and there is an increased chromosomal fragility. So we have to do the chromosomal fragility test to diagnose the Fanconi. Dyskeratosis congenita, reticulated disc and hyperpigmentation, you will find clinical feature, nail dystrophy, mucosal leukoplakia, multiple gene regulating the telomerase length, complex and sheltrin protein, and shortened telomeres in a flow cytometry. Sherman-Diamond, so you know that pancreatic dysfunction is there, various skeletal deformities are there, recurrent infection and myelodysplasia, and AML can be found in a higher frequency in Sherman-Diamond. So what is the gene involved in the SBDS gene, that is Sherman body and diamond syndrome, or this is the name of the gene, and with the abnormal pancreatic function. And GATA2 genes, GATA2 is involved in hematopoiesis. So where you find a GATA2 mutated, there may be higher chance of MDS and AML. As name suggests, the gene effect is the GATA2, and monocytopenia you find your B and NK cells, lymphocytopenia you find. Amagokaryocytic thrombocytopenia. So absence of megakaryocytes from bone marrow, myeloproliferative leukemia virus, MPL, oncogene is the responsible gene, and elevated serum thrombopoietin, MPL, undetectable flow cytometry. Now, this is a little bit of theory. Now we will go to the practical approach. What you should do in your clinic when you are dealing with the pancytopenia. As a whole, what you are expected to do. So you have to take a good history. For example, dietary history is important. You know this thing. Family history is important because it will tell you the genetic causes or point out at least to the genetic causes. So what you will get, either it's the insidious, for example, if genetic is the cause, or abrupt onset of the low blood count in previously well child with hepatitis, history of drug ingestion, family history of a similar disorder or genetic disorder, as I told you, history of previous cytotoxic therapy, RT, in particularly in a patient who has a previous malignancies, and dietary history as we discussed. Now, when you examine, so definitely examination is very important. For example, you examine, you find a hepatosplenomegaly with a low count PS, you suggest a blast, leukemia is the answer. You don't find a splenomegaly and you find a pancytopenia, no blast, you are dealing with some sort of a aplastic anemia, though PS peripheral smear and the further investigation will tell you more. So what are the signs of bone marrow failure? The bone marrow failure signs comes when, depend on the which cell lines, if all the three cell lines are affected because of the neutrophil are low, they may present with the sepsis or infection. Platelet are low, they may present with the pallor, bruise, and low hemoglobin, they will present with the the clinical features of the low hemoglobin like pallor. Physical signs of congenital disorder, you examine them. For example, supernumeracy digits that you can find in a Fanconi, and dyskeratosis. So you can see the thumb or other nails are not well formed. So there is a dyskeratosis and dyskeratosis congenita. Now, what you order, now you know that you are dealing with the pancytopenia. You are dealing with the maybe the probable cause of this low counter, maybe this. So we'll first and foremost important is a CBC, as I told you that CBC with peripheral smear is the most important. You ask them retic count because you know if the peripheral destruction is more but production is good, retic count will increase. But if your retic count is low, definitely production defect is there. So retic count will point out where is the defect in a production. So that is very important. Then come to, in many cases, or you need a bone marrow aspirate either to establish the diagnosis or to rule out the diagnosis. So bone marrow aspirate and biopsy, always do the biopsy in cases of a aplastic anemia along with the aspirate. So what you will see, the cellularity of the marrow, morphology of the residual cells, nucleocytoplasmic maturation dissociation. So that will be a more definitive. So hematopathologist should be of your good friend, actually speaking. Now, what you can find, there are some, I have only quoted a few abnormality you can find on a peripheral smear. Other than this, there are a lot of, for example, macrocytosis you can find. Your MCV is increased because there is a increased cell volume. That is a more, I have told you that MDS, vitamin B12, folic acid deficiency, aplastic anemia, this macrocytosis can be there. Hemoglobin and RBC count may be normal or very low and involve all three blood cell lines. Pancytopenia, you will find a lesser neutrophils, lesser platelet, lesser hemoglobin. All three lines are involved. So that goes more of a bone marrow failure syndrome. Here, what is in the picture? The hypersegmented neutrophils. They are very characteristic of a B12 or folic acid deficiency. Now, you will ask if you reach those, if you see the dietary deficiencies there, you ask for the folate in B12 level, iron studies, in serum erythropoietin level. Viral studies, parvo, B19, EBV, HIV, hepatitis B, chromosomal breakage studies, if you are thinking about in lines of a Fanconi anemia. HEMS, sucrose lysis, flow cytometry in case of a PNH, where you know there is a deficiency CD55 and 59 and correct protein, then you will ask for the HEMS sucrose lysis. Now the flow cytometry of FLAIR is the modality of choice to diagnose the PNH. Axial wrist and forearm absent radius. Now, what you see in the actually bone marrow. So you have to go every time you have to go to the lab to see the bone marrow. Bone marrow tells the many things about the pathophysiology of this pancytopenia. You have to see the cellularity, the morphology, and correlate with the peripheral picture. I will tell you the one example. For example, there is a low cellularity, more fatty cells are there, and low counts in the periphery. You are dealing with the aplastic anemia. If you are having a blast in the periphery, blast in the marrow, you are dealing with leukemia. So if you are dealing with the dysbiosis in the marrow or a peripheral blood, then you are dealing with the MDS and so on. So it depends on your marrow morphology as well as cellularity to diagnose the real cause of the pancytopenia. So now, as I told you, how we can reach to the diagnosis by seeing the marrow. So it will tell you about the it, or not only tell but also rule out the other cause. For example, acute leukemia, anemia, megaloblastic, B12, folic acid deficiency, PNH, you will find marrow hyperplasia, but with pancytopenia. Connective disorder, SLE, systemic GRA, myelofibrosis, MDS, marrow replacement by osteopath process, infiltration by lymphoma. Lymphoma, maybe you find a peripheral site, but in higher stage, this lymphoma can infiltrate the marrow, and solid tumor like neuroblastoma can also involve the bone marrow. You will find the pancytopenia here in a periphery. That will only tells you that pancytopenia is there, but when you examine them, there is a blast, neuroblastomal cells. So then you find where is the primary for the neuroblastoma. Now, how we define the severe aplastic anemia? So severe aplastic, when absolute neutrophil count is less than 500, platelet count is less than 20,000, retic count is less than 1%. So two of the associated with the bone marrow cellularity. As I told you that bone marrow cellularity is an important part, and it is less than 25%. It goes with the diagnosis of severe aplastic anemia. Now, whenever you are dealing with the severe aplastic anemia, you have to rule out with the two things. One is the Fanconi anemia and PNH. So, because sometimes only PNH clones may be there with aplastic anemia, and sometimes you are dealing with mainly actually a paroxysmal nocturnal hemoglobinuria. So you have to differentiate Fanconi anemia and PNH whenever you are diagnosing your severe aplastic anemia. We will see how we will diagnose that. So Fanconi anemia, you know this chromosomal breakage study. If you find that yes, there is a lot of breakage, if you can see in this figure, arrows are there. So definitely we are dealing with the Fanconi anemia. PNH, now previously ham sucrose lysis tests were there. Now you know you have a FLAIR test and the flow cytometry test to diagnose the cells which are lacking the CD55 and CD59. So that you are dealing with the PNH because you have the good drug eculizumab, that is now the preferred drug, and bone marrow transplant as a modality of choice for the PNH. Now, management guidelines for acquired bone marrow failure syndrome. So now it is actually not called a aplastic anemia because not only RBCs are low, all the three cell lines are low. So that is why we call it as a bone marrow failure syndrome. Could be acquired, could be genetic. So how you will manage them before going to a definitive therapy? You have to manage you have to give the supportive care, because they are if you are planning them for a transplant, or if you are planning them for a immunotherapy, even then they need to be given a irradiated product. You have to give them a CMV negative blood product. Most of the time now the blood banks give you the CMV negative blood product. And so what are the treatment? Actually, it depends on the cause of the aplastic anemia or bone marrow failure syndrome. But as a common sense, we use the two. One is the immunosuppressive therapy, that is the antithymocyte globulin, 40 mg per kg for 4 days, or ALG, 3.5 mg per kg for 5 days, along with the cyclosporin, and response is 60 to 70%. This may not be applicable to the inherited bone marrow failure syndrome, where BMT is the only the choice, or bone marrow transplant, or stem cell. More specific word is the hematopoietic stem cell transplant is the choice. But here, and other causes, you can use the IST. Allogeneic bone marrow transplant, the success rate is 80%. In Indian scenario, where everyone cannot go for a transplant, immunosuppressive therapy is one of the alternative option. Corticosteroid nowadays rarely it is used, depending on if you are dealing with the hemolytic crisis, or if you are dealing with the actually etiology as a hemolytic or autoimmune, corticosteroid is helpful. So these are a few mode of actual treatment or management, but definitely you should know the exact diagnosis, then only the treatment can be planned. Okay, so now this is the most important part. We will discuss 3 cases, and most of the questions can be answered in these 3 cases. So first case is of a 12-year-old girl present to local doctor with a fever, lethargy, gum bleed, epistaxis. So fever, sign that maybe a neutrophil are low. Lethargy is a non-specific symptom but important. Gum bleeding, that maybe platelet are low, and so he does a dengue serology and gives platelet transfusion and IV antibiotic. It's okay. Now, what is the importance is that when you examine that, their height by weight ratio is 50% for the age, pallor and pateshi present. There is no organomegaly. If organomegaly is there, then differential will go some another direction. No dysmorphic features is there. 12-year, these genetic predisposition patient come earlier. So she's a 12-year-old girl. So we have to see all this thing in our mind. What are the question? Now, duration of illness is important. You have to ask them whether it is a last 15 days or last 20 days, or it is from few months. You have to order CBC. So what do you find? WBC is low, 2.14. Hemoglobin is low. TLC is platelet is low, only 15,000. If you see the MCV, it is 110. And if you find reticulocyte count, so 1. And this is the peripheral smear. So there's the macrocytes are there. You can see. And what you will investigate next? You see the viral serology or B12 folic acid or bone marrow. You jump for the bone marrow aspirate or bone marrow aspiration and biopsy. So you have done the bone marrow. Okay, so then you have seen the PS. There is a macrocytes in bone marrow. Bone marrow is cellular and show a multilineage dysplasia. So multilinear dysplasia can be in a MDS, can be in a B12 or folic acid deficiency, nutritional deficiency. So when you order Pelar and lethargy, they are complaining for 5 months. Malignant condition have actually not so long duration. They come within a 15-20 days or maximum of 1 month duration of complaint. So you find the WBC 2.14 same, and you find this peripheral smear, you have a hypersegmented neutrophils. So you made the diagnosis of a B12 or a folic acid deficiency. You have ordered them. So there is a dietary history. You have to take the dietary history examination, moderate pallor, hyperpigmentation of knuckle, liver 2 cm below costa margin, spleen not palpable, peripheral means so macrocytosis, and leukocytes and platelet are reduced, B12 and folate level. You have sent here, folate deficiency was found, and so you have corrected the folic acid. Now child is okay. Now come to the our previous this flows. So apply all this thing to this flow. You have confirmed this pancytopenia by CBC. Now, initial rule out effect of drug, you have asked them if she is taking some drug which is myelotoxic. So you find no, then initial workup you have done. Peripheral smear is the most important. If peripheral smear showing macrocytosis, consider MDS, megaloblastic, aplastic. So you have a 3 differential diagnosis. Now you want to know whether there is a production disorder, there is a consumption disorder, where the peripheral destruction impaired production. So we go with the history. So you find in a history that there is a low height is not achieved, or weight is not, she is not gaining the weight, eating disorder or bariatric surgery, malabsorption, inadequate intake. Inadequate intake may be the reason that she is having a folic acid deficiency. So if you go by this chart, most of the time you will reach to your diagnosis. You replace your vitamin, she is now fine. So management is a folic acid deficiency is there. So you supplement with the folic acid. Case 2. Now another one, 4 years. So age is 4 years. It is not a 12 years, it's a 4-year-old present to his pediatrician with a growth failure. Only one complaint is of growth failure. You have taken the detailed dietary, obstetric history, past history, nothing remarkable elicited. Family is middle class, have an older son and daughter who are 90% of height and weight. General examination, darker pigmentation from parents and other siblings. No other phenotypic feature observed. Pallor is noted. CBC peripheral smear exam, reticulocyte, macrocytic anemia is there. Reticulocytopenia is there. Reticulocytopenia means something has happened to the marrow. That is why it is not producing a good amount of RBCs. So CBC is a low hemoglobin, low WBC, low platelet, PS showing no abnormal cells. So you have rule out acute conditions like leukemia. Few macrocytes are seen, reticulocytes are low, and this is the marrow. What you are finding the marrow, the empty spaces actually. Severe aplastic marrow with less than 25% cellularity. What you are seeing is the fatty cells actually, and the empty marrow. That's not a healthy cellular marrow. So you know you are dealing with a severe aplastic marrow. As we discussed, when you are dealing with a severe aplastic marrow, it could be acquired, it could be a congenital. So you know the boy is only 4-year-old, and here you want to differentiate if you are not dealing with the genetic. So look for genetic syndrome, chromosomal breakage, test for PNH. Okay, so here the same. You go with this confirmed by the CBC. Child is having a pancytopenia. Initial workup, you have seen peripheral smears in macrocytosis. Okay, so you are dealing with either aplastic, MDS, megaloblastic. Okay, so there must be some production disorder. You know, child is good, taking good nutrition, so it may be a non-nutrition cause. And you have performed the bone marrow biopsy, and bone marrow biopsy, you have find there may be hypoplasia. So maybe 3, either acquired aplastic anemia or congenital bone marrow failure syndrome or hypoplastic MDS, but you could not find any myelodyspoisis. And so you are dealing with either acquired or a congenital. When you have done all those, then added test you have done, and then you will reach to the diagnosis. Now this is the one more case. This is the our own word case. So one thing is that he's a leukemia child. So leukemia itself causes the pancytopenia, or they may go with a high count, but effectively they are the pancytopenia. So it's a pre-BALL. This case will tell you what may be the differential diagnosis of pancytopenia who are getting some sort of a chemotherapy. So drug-induced pancytopenia we are talking, and we will talk one step ahead. why this pancytopenia has happened in this drug, alone drug induced, or something is also there. So we are treating with the BFM protocol, and he came to us this time in a reinduction phase B. These are the chemotherapy agent what he is receiving. There is a 6-TG, 6-thioguanine, there is a cytarabine and intrathecal methotrexate what he has received. Now he has a fever of 1 day, and there is some difficulty. Vitals were stable, system examination normal. This is the presentation count: WBC 130, ANC 0, platelet 70,000, hemoglobin 5 point. So the pancytopenia. We have asked for the peripheral smear. There is no blast. So we are sure we are not dealing with the relapse of the disease. It could be relapse, but then that should be ruled out by the bone marrow. Okay. So we started on a first antibiotic. We gave the GCSF. We gave the supportive measure, platelet, and other. It turned out to be a urine culture E. coli and blood culture against E. coli. That was MDR. So at this time point, at different point, 48 hours, vitals stable, fever and pancytopenia persisting. We change antibiotic to Miro, and even then 72-hour fever is persisting because he is a neutropenic, pancytopenic. So when the child comes with the neutropenia, the sepsis is the presenting symptom. Okay, so fever persisting, vital stable. We continued with our antibiotic, meropenem because prophylactic caspofungin will be added. 72 hours later, so this MDR is persisting, and that is sensitive to only to colistin fosfomycin. We added fosfomycin. Now, at this time point, what is the differential diagnosis of pancytopenia? It could be a sepsis, but he is well covered with antibiotic. But sepsis can cause a myelosuppression. Drugs 6-TG can cause a myelosuppression. Nutrition, we have seen that he is taking good diet, and before that, B12 and folic acid were normal. Relapse of the disease can be there, though PS was normal. So we need a bone marrow. Okay, we did a bone marrow. There is a severely hypocellular aplastic marrow. It could be a chemotherapy-induced suppression, but what is the not a typical to that? They most of the time it is a 10 to 14 days myelosuppression is there, and then the recovery is the rule until it's the myelosuppressive or a myeloablative therapy is not there. So some prolonged pancytopenia because of the inadequate metabolism of the drug. So we are dealing something that is not so common. He has a previous history when he got the same drugs with other doses. He has a prolonged multiple interruption of the tablet 6 MP, and during consolidation due to severe neutropenia, and hospitalized for febrile neutropenia during induction phase 1B, where same drugs were used. So then we asked for the gene analysis, and there TPMT, which is responsible for metabolism of the 6-thioguanine and NUDT. So we found that there is a homozygous for 42C41T variant. So we found that NUDT is homozygous. That is why he is not able to metabolize 6-TG and causing a prolonged myelosuppression. This was the report. And so this tells us many things. What drug can cause, drug metabolism can cause, and sepsis can cause, and you have to rule out one cause by another cause. Now he is on a maintenance. He has recovered. We have to give the granulocyte infusion, another thing also. So now coming to our chart. So rule out effect of the drug or toxins. In this, we have to keep this thing in our mind. These drugs can cause prolonged myelosuppression or pancytopenia if the metabolism is not adequate. Okay, so here we have done the initial seen the peripheral smear. There is the pancytopenia confirmed, but we could not macrocyte or other feature which were there in earlier children. So now there must be, we are dealing with, we have done the, we know that it is not coming up. There must be a production disorder, not a nutritional and non-nutritional. We perform bone marrow. Bone marrow is a hypocellular. Hypocellular is it's like a acquired aplastic anemia because of some drugs. The good thing with the drug, if you remove the drug, the marrow most of the time is recover. Some exception are there. For example, chloramphenicol, where they need a definitive treatment. So this is an approach to the pancytopenia, but you have to think every cause of pancytopenia when you are dealing with the children with the pancytopenia. So this is a little bit of phenconemia. There are hypoplastic or absent thumb, capillary spot, hyperpigmentation, short stature. You may find PDA, pulmonary stenosis, hypogonadism, hematological, as I said, macrocytosis is there, pancytopenia is there, and few progress to MDS, leukemia, and solid tumors. Disc keratosis congenita, nail dystrophy is there, hematological feature, you will find a pancytopenia, they will change into MDS, leukemia, and solid tumor as well. So when to treat Fanconi, hemoglobin less than 8 or ANC less than 1000, androgen usually previously we were using, but now the transplant is only the mode of treatment. Disc keratosis congenita, same bone marrow they need, and amyloidocytic thrombocytopenia, they need a bone marrow transplant. Same with the diamond blackburn anemias. Shaman diamond. So if you see all these congenital disorder need bone marrow transplant as a therapy, but they should be diagnosed promptly and refer to the transplant center so that they will not receive a much blood product which can cause a aluminization to them. So this is our approach to the pancytopenia. Thank you. Now, if anybody wants to ask the question.
Pankaj sir?
Hello.
They, yeah, sorry.
Hmm, hmm,
So there are a couple of questions. I was not in the session. So
hmm.
have you answered those? COVID can cause
Yes,
pancytopenia?
yes. So we have not seen that COVID is causing a pancytopenia, though we have two patients of MISC. So that is, I think, common scenario. But pancytopenia is not common with the COVID, and I don't find any literature review that is saying that it can cause a pancytopenia. But it's a virus. Later we know that.
Okay, sir. When we suspect HLH, like sometimes we get this
Yeah,
call
yeah,
by
yeah,
general physicians who are sending patient in MISC and
mm,
high CRP,
yeah.
low platelet,
Mm,
low hemoglobin. So at this moment, at the peripheral setup, if they have not done ferritin, how
mm.
can when they are suspecting HLH, how should they proceed to evaluate that when they
Okay.
are dealing with bicytopenia and they want to rule out HLH?
Yes, sir. So good thing actually we also find when the physician or pediatrician send us a patient of HLI. So there are very actually you see now they most of the time there are the two type of HLH. You are aware of this thing. One is a primary, another is secondary. So first we have to see the presentation. If you are coming, you are getting a 6-month-old boy with the pancytopenia with hepatosplenomegaly. The one underdiagnosed condition is HLH. The peripheral smear will show you the many things. It will rule out the leukemia definitely, because leukemia is also come with the same thing: high grade fever, lymphadenopathy, hepatosplenomegaly, may or may not be pancytopenia. So you have to do so within 6 months. You are maybe dealing with the primary HLH. Later on, secondary HLH is not so common in general population, but viral infection can lead to the secondary HLH. So approach to like this, the same as for pancytopenia. If you have seen this slide, it's a very important slide actually. Can you see this slide?
Yes, I can, sir.
Okay. So if you go to this here, if you see, if you can find out, first thing is the most important thing is the your peripheral smear. In
Yes.
peripheral smear, you will confirm what you are dealing with, and then secondary, you go with the another thing is that there whereas the malignancy, definitely PS will rule out. PNH, hemoglobinuria will rule out. Then coming to the autoimmune condition, you know this previous history of blood transfusion, or you know directly the this is the cause of autoimmune hemolytic anemia, and you rule out the drug. Now the one differential is HLH. Then in periphery, you can ask for the triglyceride, you can ask for the fibrinogen level, you can do the bone marrow in peripheral, and you can find the hemophagocytosis, high grade fever, low count, hepatosplenomegaly. With supporting this thing, you might be treating or dealing with the HLH in primary,
Sir,
secondary, depending on the age and presentation.
how many cases of HLH with COVID have you seen lately? Any case or some cases or what it is? Have you seen anything?
We have not seen last 3 year means sorry, in the last 1 year, we have not seen HLH along with the COVID.
Okay.
AML patient, one is AML, another is the Burkitt's, who develop the COVID, and post COVID they develop the MISC.
Okay. Okay. Okay.
So we confirmed the MISC and they responded well to the
Okay.
IVIG and steroid, as the we follow the those protocol for this thing.
Okay. Fine. Fine, sir. Thank you for again. Thanks. I have actually followed around 40 minutes, but at the end I was not able to follow. That's why I missed this slide.
Okay.
But because this bicytopenia issue and query
Okay.
has been there for quite some time, and now HLH being aware, many general physicians know this term HLH, and they
Yeah.
know ferritin भी बढ़ता है और
Right.
ट्राइग्लिसराइड भी बढ़ता है तो ये ऐसा आ रहा है इसे HLH की तरह treat करो and then it is difficult for us to tell them yeah this is HLH, this is not HLH. So that's why I wanted an easy reckoner for them to understand. So what I understood is hepatosplenomegaly with bicytopenia with high grade fever, think
Right.
about HLH. If there
Right.
is no hepatosplenomegaly and the condition and fever is not high grade along with other possibilities, keep your mind open and do not just take HLH as first diagnosis and don't start ruling it out. Just give time, see the diagnosis and then proceed.
Yes, very right, very right. Because in HLH, you have a definitive this thing treatment plan. For example,
Yes.
secondary HLH, you may rule out some infection, and if infection is goes down, Along with a small
Actually,
amount of a chemotherapy, the child can be better, or he may require a full protocol, depending on the clinical scenario. Primary,
100%.
definitely transplant is the option.
Okay. Thank you, sir. Thanks a lot, sir. Thanks for the
Welcome.
time.
Welcome.
Take care.